I will talk about glycemic control in the intensive care. I will definitely introduce the STAR protocol, especially because the same name than the conference. Yeah, it has the same abbreviation than the conference. However, I will talk also a little bit wider context of the glycemic control and the protocol implementation. We use the so-called digital twin technology, and this digital twin technology, I think, can be a key point to make the health treatment more efficient or increase the efficacy and increase the productivity. I will talk about a little bit later about that one. So let's talk about the problem, the motivation. I am probably the man who knows the less that in this room that the hyperglycemia is a common complication in the intensive care unit, and it has a negative effect on long-term outcomes, clinical outcomes. The therapy what we use it for is insulin therapy. However, the dosing, how can I treat the patients is challenging due to the complex physiological system and due to the variability of the patient. That inter- and intra-patient variability is extremely high in this sense. And whenever whoever wants to make a treatment, they have a requirement, and the most important requirement is patient safety. In this concrete term, in concrete case, the patient's safety can be translated for a very simple rule. We have to avoid hypoglycemia. If we administer too high level or too much insulin, then we will cause or will harm the patient. So we want to have the blood glucose level above 4.4 or whatever protocol you follow. And the second requirement is efficacy. We want to keep the patients in a normal glycemic range. The original goal was to bring down the blood glucose level. But we can go further away with the requirements. We also want to provide enough energy to the patient, so the feeding of the patient has to be also considered. And I would like to say that after all these things, those clinical requirements, I want to also somehow control the burden of the nursing and clinical staff. So I have to optimize this one. And I will skip some nice slides just because I will consider your time, and I just want to outline that STAR, we have multiple versions of STAR, one for the adult ICU and one for the infant ICU. So those are those slides were basically concentrating why we should do this treatment on the infant ICU. So I promise the very last requirement leads us a little bit wider context, and why I want to spend a few minutes about that one. If we consider the last couple of decades, we can see the significant difference between the growth of the GDP and the growth of the healthcare costs. If you see the gap, this gap is drastically growing. Which means that governments cannot finance the healthcare on the same level as they financed even 10 years ago. If you see the second slide, it says a little bit, it says the same thing but in a different way. The green bars actually shows what is the growth of the health expenditure in the private sector, the family spendings. And the other two bars, the green, the one is the GDP, the growth of the GDP, and the other bar is the growth of the government-financed health expenditure. What we can obviously see, these are the seventh largest European states and the average in the European Union. What we can see a clear shift of that the families finances their healthcare costs. And it will cause, of course, inequality in excess of healthcare. So I don't want to go too far because it leads us very far away. I want to just outline. We have to concentrate whenever we try to provide a better care. We also have to consider the cost. How can we decrease the cost of care? And what I would like to prove by the end, that using the approach what I will introduce, it can help both of them, so we can increase the productivity. So let's talk about STAR. STAR is a relatively simple protocol. If you just want to understand how does it work, we make frequent blood measurements, 1 to 4 hourly measurements. Then we use a decision support system which will give us a suggestion, which will give us a suggestion for the optimal treatment. And the clinical staff will have an option to either accept or override or change the dosing. And it's very important that in this control loop there is always a nurse or a clinician or a doctor. Of course, the main challenge, what is in those boxes and what are the methods that we apply there, what you can see on the right up corner. What we do, we use models. We use models of the physiological processes. It is a big challenge. How can you find and develop a model which can be used on the bedside, that can be used on all those decision systems? However, we are hopefully good engineers or good biomedical engineers, and we can develop always a model which could be used. Of course, if we are engineers, models are not only just nice figures that I showed. Of course, we have a mathematical representation. In our case, this is a simple differential equation system, and I can talk about this figure, just this figure for hours, so I will just skip those. But I outlined that we do have some parameters, patient parameters, in this case insulin sensitivity, which have an important role later on. So as soon as we have these models, we can make very tricky things, or it's not tricky, but let's say very helpful things or methods for those. But let's go back to the protocol, and let me introduce a little bit what we do on that right-hand corner in the decision support system. The decision support system basically mimics what we do actually on the bedside. I will come back to this sentence later on. First of all, based on the current measurement, we identify the current state of the patient. This is the key step. After I do have the current state of the patient, I will predict the future outcomes, the future, let's say, trajectory of the patient state. And I will predict what is the range of the patient, what its patient state will have in 1, 2, or 3, or 4 hours. But as soon as I do have that one, I can make basically simulations. I can compare, or I can select the optimal treatment, because if I do have the model of the patient, I can simulate the outcome of different alternative treatments. I can first define what is the outcome, what are let's say the lowest and highest blood glucose levels in our case, but I also can handle the risk, because I can exactly know what is the likelihood that this patient will fall, or the blood glucose of this patient will fall in a given range. This is what we do. And actually, this is, if you think about it, you do the same thing when you make decisions without any kind of decision support system. I will come back to this sentence later. So, just giving a few details. What we have, the model allows us to identify the patient state, and the patient state is, in our case, is defined by the so-called insulin sensitivity of the patient. We are lucky because we worked a lot on what are the appropriate parameters to describe the patient state, and insulin sensitivity that is found to be appropriate for that one. If you have the blood glucose measurements, if you know the treatment, the insulin and nutrition intake, then you can calculate this one. The other question, how can I predict the future state of the patient? And for that one, we use a so-called distribution function, or probability density function of the patient, but based on the previous treatments. We collect the patient. We do have a relatively large data set of the patients, and we can use. We have multiple methods. We are working on even using artificial intelligence method right now, I'm just testing, but the most important thing, we will have a prediction for the future. And as soon as I have this prediction, this will be basically a density function, probability density function. Then it is how I define. I take the 5th and 95th% of this function, and then I can translate this patient state into the patient outcome. So I can calculate exactly what will be the patient blood glucose if I give a certain treatment. This is how I do it. So I can basically calculate what is the range, blood glucose range, what will the patient fall after the treatment. Just going a little bit faster because I'm running out of time. So as soon as I have the future patient state, I can calculate the blood glucose levels. So, and once again, a little bit wider context. What we do is nothing else what we did actually, and now it's called like digital twin technology in medicine, which is borrowed from the industry. I mean, the terms borrowed from the industry. The current treatment is on the left-hand side. We make measurements, on the bedside. We make decisions, but of course, always human-guided measurements. Always doctors and nurses are involved in the decision. On the right-hand side, you can see the digital future. And what I really want to outline, the key tool, the key technology, what you can use or you have to use all the results of the engineering of the last couple of decades is using models, using digital twins in medicine, because this allows you to use automation. It allows you to quantify risk. It allows you to define the outcome of all kinds of treatments if you have an appropriate model of the given physiological organ or physical process. This is what actually, which is the offer what we say. And of course, what we learned, especially with STAR, we assume that the largest problem to find an appropriate method, find an appropriate implementation, and start distributing it. What we learned, it's very important to how to introduce it, how to connect it to the digital health records, and how can you implement in the practice. So let's see what is the real outcome, what can be used in the practice. The very first version of the STAR was actually implemented as a tablet application. This was the decision support system. You can see on the up left corner. I will not go to the detail. I'll come back to the nice video. So this is basically how it looked like. From engineering point of view, with no multiply screens. We tried to develop a very convenient or user-friendly user interface, and nurses liked it. This is how it looked like. This was just one of the main screens. But right now, what we have and introduced in Liège and Christchurch, a new implementation, actual version, which is called Glucomel. Glucomel is already a tablet or laptop-based implementation. We have the user interface. We have the controls on the left. All the clinical parameters what you have to set, how much insulin you want to have, what are the nutrition levels you provide for the patient. And on the right-hand side, you can see the figures. You can see what is the current state of the patient, was the history. On the top figure, you can see the blood glucose level. Those are the measurements and the trajectory of the blood glucose. There is a red bar showing the current time, and what you see on the left, on the right from this bar is the future. The future, which corresponds to the treatment on the right-hand side. And of course, on the bottom, you can see the insulin sensitivity. Let's just concentrate on the right up corner. What we can see, yes, this is the blood glucose range which will happen if I use that treatment. Why I don't use it? That screen to let the doctors or nurses adjust the treatment as they want. And what we can do, what you can see on the video, it will show exactly what will happen with the patient if I adjust one of or other parameters. Well, I mean, there's a common statement: simplicity is the ultimate sophistication. I mean, this is a 4-year-old lady who's just learning how to treat the patients in the ICU. So, once again, I just show the screen. I mean, since I'm running out of time, I just mentioned that a fully integrated feeding regime is integrated into the system. So this was actually was started in EULA hospital when we started to apply. They wanted to have a quite complex feeding regime. Now it's part of the new STAR, which is now called Glucomel. And just I want to mention that this approach, this digital twin approach, can be applied for other organs. The offer for mechanical ventilation, we already have, or part of the route, we already have applications for that. Those are just simulations. I will not stop because I'm already run out from my time. For fluid resuscitation, fluid therapy, we are just about to collect data for validating in clinical cases. And of course, we have very nice results. Trust me, this is the preview. I mean, the original version of STAR used in a couple of thousand of patients. You can see nice numbers there. And this is the recent results from the new Glucomel. Again, we are over a couple of thousand treatments. It is regular use or normal routine use in Christchurch, in Liège, and some other hospitals are interested in to introduce. I will not go into the details, but it's really the last presentation. I just quickly, sorry, no. I think I should go back if I can. Maybe yes. So, clinical results. 34% reduction time on insulin. 33 reduced reduced ICU stay. 35% reduce in workload, and those can be turned into dollars or euros or whatever. Sorry, and just go to the very end. So what we have to always consider that humans are horribly variable, and ICU patients are even more. Those are the worst humans, let's say, in this sense. Digital twins is an opportunity to enable more productive healthcare, giving better treatment, more personalized, and better clinical outcomes. And let's say what we need is basically just a little cultural change, which definitely is a big barrier, but I think we can come over. Because if we do not, others will. I mean, I introduced STAR 5-10 years ago for the community. Now in Liège they are implemented. There is a startup company who is already providing this as a service. There are some take-home messages at the very end. And I must tell, this is not a one-man story. This is a group of researchers, especially from University of Canterbury, from New Zealand, University of Liège, and Professor Knut from the Furtwagen University, and there are a couple of hospitals associated with this research team. We have multiply projects. This is some kind of nice picture summarizing the potential contributors. Thank you very much for your attention. I'm looking forward to questions.